that we needed a bit of breather from organising lectures, and maybe the Head and Neck Centre needed a bit of a breather from doing this sort of thing. So we've given it a full 6 month break, and we've come back and we're putting this lecture series together. We've got 4 confirmed lectures and one slot just to fill. So I'll come back to tonight's in a moment with Dr. Shin. But next Tuesday, so the other thing to point out, these lectures tend to be on a Tuesday evening. That's been our habit, at 7 o'clock. Now tonight's the odd one. It's a Thursday, so we've started on a Thursday, which is fine. But all the ones after that, I think, will likely be on a Tuesday at 7 o'clock in the same slot and in consecutive weeks. So starting next week, we'll have Dr. Amy Harding, and Amy's a translational basic scientist who's joined the centre quite recently as a lecturer, who's going to present on modelling the extracellular matrix in head and neck cancers. And she's got some great lab work going on, developing tumour models from culturing the cancers that come through the head and neck centre and the oral dysplasias. The following week, the 27th of January, we've got Dr. Gemma Cherry, and Gemma is a methodologist who's going to talk about outcomes in older patients with head and neck cancer, which is a very topical subject because there's, like a lot of cancers, there is a bit of a trend towards more and more elderly people, which gives us challenge as how to manage elderly patients. So that's really quite important. And then the other one we've got confirmed is Professor Mairead Evans, coming from Velindre. And Mairead's got an honorary chair at the Head and Neck Centre and has worked with us for many, many years, I think over 20 years, and in particular has worked with us on the Pathos trial. And so we'll just finalise the full programme over the next few days, but if you can make a note in your diaries for those, they'll be excellent, and I think very varied lectures. I think that's the main thing. It shows the real depth and breadth of the activity of the Head and Neck Centre, that we're obviously involved in research, but we're also involved in clinical management for all things head and neck, and obviously in education as well. And Debbie, remind me, I'll also put a slide up the next lecture, just to give notice of all the courses that are run for the Head and Neck Centre. There's about 7 or 8 courses that are now run, annual courses and biannual courses that are anything between 2 days and 5 days. So we should give a little bit of notice to that. So I've waffled on just a little bit there, just while everybody joins the lecture. Tonight, it's my pleasure to introduce Dr. Ikshin Shin. And Ikshin Shin is a fairly new appointment. I think 2025, was that right, Ikshin?
Yeah.
Fairly new appointment. And one of the things that we really sought out to do many, many years ago is build our capacity in medical oncology in early phase drug trials. And it's absolutely central importance to the future of therapies for head and neck cancer. And Dr. Ikshin Shin is actually the 3rd medical oncologist at the University of Liverpool to work with us in the Head and Neck Centre. So we're really delighted about that. That sounds like a real success. She was originally trained in, I think, Birmingham, and did her medical oncology training in Birmingham. She then did a PhD during a higher training, and a PhD's been in immunotherapy and toxicities. She then did a fellowship at Christie Hospital in Manchester, and then she joined us at Clatterbridge Hospital and the University of Liverpool as a senior lecturer and an honorary consultant in medical oncology. And she's joined us recently, and I will ask Debbie to start recording and introduce Dr. Ikshin Shin. Thank you, Ikshin.
Yeah, thank you very much for the kind introduction, Richard. I'll just try to share my slides. Okay, does that come out okay, Debbie?
No, we can't see. Oh, they're up now. Thank you.
Okay, brilliant. So thank you very much for allowing me to speak today on a Thursday rather than the Tuesdays. So today I'm going to present on some of the up and coming new therapies currently research at the moment. So specifically bispecific antibodies and antibody-drug conjugates, or ADCs, in head and neck cancer. So I'm happy to take questions at the end, and yeah, so just to start. So just a brief introduction. We know that head and neck cancers can be a poor prognostic disease. Recurrence rates are high, almost up to 60%. And in patients who do recur, their prognosis is also relatively poor, with a 5-year overall survival of up to 45%. And for patients who are PD-L1 expression positive, immunotherapy in the form of anti-PD-1 inhibitors is the standard care treatment for these patients. However, only a small subset of patients actually have benefit from this treatment, so let's say about 10 to 20%. So there are many studies out there to try to develop novel immunotherapeutics to improve the responses of our treatments. And bispecific antibodies and antibody-drug conjugates are one of the ways to target these cancer cells by using or targeting specific tumor antigens that are highly expressed in head and neck cancer. So I'll talk about bispecific antibodies to begin with. So these are engineered molecules which are designed to target 2 different antigens. And by doing so, they overcome the challenge of traditionally monoclonal antibody treatments, such as cetuximab, Herceptin, for example, that are used to target a single antigen, as this often leads to resistance and tumor escaping this effects from the therapy. So in the diagram at the bottom, this is an example of a classic human antibody where it's shaped like a Y shaped molecule, and you have the antigen binding sites, which consists of 2 identical light and heavy chains, and this area is also called a Fab component. And you have the FC component, which is which binds to the effector cells like leukocytes and T cells. And in treatments where they're designed to be a monoclonal antibody, typically they bind to one single epitope or from a single target antigen. And if you've got a bispecific antibody, they're usually made up of 2 different heavy and light chains, which allows them to bind to 2 different epitopes, usually from 2 different tumor antigens, so increasing their therapeutic effect. So there are many ways we can manipulate the structure of the antibody in order to achieve the optimal effect that we want for different clinical contexts. And in the top right here shows the different building blocks, if you like, for the bispecific antibodies. So this area has the different ways that the Fab or antigen binding components can look like, and a slightly different FC portions as well. And generally, the bispecifics are categorized into 2 different formats. So we have the fragment-based formats, which do not have the FC component attached to it. So these molecules are generally small and simpler in structure. And then the FC-based formats look more like the typical antibody, and with the FC component attached. And these are more stable in the serum and have more vector distributed in the plasma. And more recently, there are also other ways that the bispecifics can be designed to increase the number of antigens that they can target. So we have trispecific antibodies, for example, and some of these are already being used in clinical studies and practice as well. So the mechanism of action of these molecules can be determined by the targets. The most common way that these molecules act is by being like a T cell engager. So, for example, the bispecific antibody as shown here will attach one arm to the CD3 subunit of the T cell receptor, so attracting the T cells, and the other arm will attach to tumor-associated antigen from tumor cells. This creates a synapse and release of perforin and granzymes, and these can lead to tumor cell lysis and killing of the cancer cells. And the bispecifics can also attach to other types of immune cells, such as the gamma delta T cells, and also the innate immune system like NK cells, for example, to achieve the same therapeutic effect. The other way that bispecifics works is by modulating the immune checkpoints. So, for example, here they can latch on to PD-L1 and LAC3, and by blocking the effects of these immune checkpoints, they can reactivate the tumor's T cells to cause tumor cell lysis and decrease expressions of these immune checkpoints, which are usually inhibitory. And the third way that this bispecifics can work is by inhibiting the downstream effects of signaling pathways that generally lead to tumor growth and proliferation. So, for example, here it can attach to two different tumor antigens in two different signaling pathways and inhibit its downstream effects. It can also prevent the dimerization of certain signaling pathways that involve the receptors to be internalized and prevent them from eliciting its downstream effects. So I'll just go through a few examples of bispecifics that are being widely researched in head and neck recently. So pembrolizumab is a human common light chain bispecific antibody targeting EGFR and LGR5, which are typically highly expressed in head and neck squamous cell cancer. And LGR5 is also usually expressed in the cancer more stem-like cells. And the way that pembrolizumab works is threefold. So it can inhibit the EGFR signaling pathway and prevent cancer cells and prevent cancer growth that way. It can also attach to LGR5, causing internalization of the EGFR receptor and degrades the EGFR molecule in this way. And LGR5 is usually highly upregulated when EGFR, when the tumor becomes resistant to EGFR, so it's highly expressed in these tumor cells. And the other way that this drug works is by engaging the other cells of the immune system, like NK cells or macrophages, in order to elicit antibody-drug dependent phagocytosis or cytotoxicity to kill the cancer cell. So in the phase 2 trial, looking at pembrolizumab in previously treated recurrent metastatic head and neck cancers, the waterfall plot is shown here, showing where each bar shows the individual patient and the percentage change of their tumor sites from baseline. So the bottom here are all patients who have experienced tumor shrinkage. The overall response rate was 36%, so that's quite a modest response, and it has a disease control rate of 64%. And they then also looked at patients in the first line setting who were PD-L1 positive, and pembrolizumab in combination with pembro achieved even higher responses with 67% demonstrated in this waterfall plot. And this effect is seen regardless of PD-L1 expression, so both in PD-L1 low expressors and high expressors as well. And from this data, pembrolizumab has now moved into the phase 3 trial. So one looking at patients with previously treated head and neck cancer, which is also running in Clatterbridge. So that's our MERIS MCLA trial. And they've also opened another phase 3 trial in the first line setting as well. So it'll be interesting to see those data coming through. Another treatment bispecific, which is moving quite quickly at the moment, is amivantamab. Again, this targets EGFR and MET, which again is usually regulated with EGFR resistant tumors. and presents in high number of cases, often associated with poor outcomes. This bispecific therapy is also being improved in other tumor types like EGFR positive non-small cell lung cancer. So the trial which looked at amivantamab in head and neck cancer is the origami trial. When they looked at patients who had prior treatments, they found that in the waterfall plot, the objective response rates were up to 45%, with a clinical benefit rate of 76%, some patients and the patient achieving a complete response as well. And in terms of how quickly this drug works, when they look at the spider plots, they found that the median time to respond was within the first 6 weeks or so. And patients who had complete and partial response achieve a median duration of response of up to 7.2 months. In terms of toxicities, there was quite a high number of patients who experienced grade 1 or higher treatment-related adverse events, but about 40% of them were grade 3 or higher. The types of toxicities we see is typical of MET inhibition or EGFR inhibition, for example, hypoalbuminemia, stomatitis and dermatitis, rash, which you typically see with EGFR inhibition. And the third bispecific that I'd like to talk about is Ficerafix alpha or BCA101, and its targets again EGFR and TGF beta, which is known to have immunosuppressive actions by negatively regulating the innate and adaptive immune system. So in their phase 1 trial, where they look at BCA101 alone plus minus pembro and a selection of around solid tumors, they did see some clinical activity of this drug in head and neck cancers, and the safety profile was manageable. So this figure here shows an example of patients who was treated with the combination of BCA101 and pembro, and the blue bars were patients who had head and neck cancer, and in orange are patients who had anal cells, SCC. And I think out of 15 patients who received this combination, there were 4 patients who achieved partial responses. So these were patients who demonstrated by the red triangles. And this CT imaging shows a patient with head and neck squamous cancer who is pembro and cetuximab refractory, and demonstrated that there was responses seen at both the initial tumor site and at the metastatic site as well from baseline to week 16. In terms of the treatment-related adverse events, there were about 87%, and typical of EGFR inhibition, again with dermatitis. The serious treatment effects were higher, slightly higher in the combination arm, and there was one dose-limiting toxicity where a patient had grade 3 hematuria and anemia. So again, in the dose expansion cohort of this study, looking specifically in treatment-naive resectable head and neck cancer who were PD-L1 positive, the combination therapy showed quite a good overall response rates of 54% among 39 patients who were evaluable in the study. And reassuringly, patients who were HPV negative also did have a good response, which over about 21.4% HPV negative patient having complete responses. And these were also durable responses, as you can see, where 56% had responses for 12 months or higher, and the PFS was 7.4 months, and over 50% 12-month overall survival rate as well. So following from this data, there is currently a randomized phase 2 to 3 trial of this bispecific in the first line setting, randomizing this combination with pembro alone. And so the study is also now open in Clatterbridge, and we just received the green light for enrollment. So some of the challenges to do with these therapies are, as you can appreciate in the first two slides, that these designs can be quite complex. So you need a specialist center and infrastructure to manufacture these molecules. And there are also quite large molecules with short half-lives and require weekly or bi-weekly dosing. So delivering them in practice may be a challenge if the chemo unit capacity is quite full. Some of the toxicities, which I'll touch on later in the next slide, like cytokine release syndrome or neurotoxicity called ICANS, quite unique to these therapies and may require additional training for oncology staff. And as with most treatments, there's also development of resistance to these therapies, which can be multifactorial, as demonstrated here. So it could be due to the tumor-related factors, so perhaps target antigen is diminished or lost, and there could be heterogeneity. So one way to overcome this is to design tri-specific antibodies that can target multiple tumor-associated antigens. The T cell characteristics around the tumor cells are also important, and if there's less T cells or they're less fit or exhausted, they may not act as well. So one way to overcome this is to combine with immune checkpoint inhibitor, as some of the trials have been doing, to reactivate these or stimulate these T cells. And the tumor can also be surrounded by immunosuppressive microenvironment, typically with Treg and T cells. So combining with the antibody that can target these Tregs may also prove to be beneficial. So touching on the toxicities, as previously mentioned, cytokine release syndrome is the main one that we look up for. So it's a systemic effect where caused by the presence of pro-inflammatory cytokines that are released by the T cells that are activated by these therapies. It typically occur quite early on during the treatment, and when the patient achieves the full dose of their treatment. They can present with quite mild flu-like symptoms, but they can quickly develop into more serious events, and including multi-organ failure. And some of the ways to reduce the severity of this is by using pre-medication, like steroids, antihistamines, for example. And then we have the neurotoxicity ICANS, which is quite rare, but it's something that we do monitor for in these patients. They can develop with or shortly after CRS, and they can present quite subtly, like mild confusions, maybe their handwriting has changed, for example, but they can also quickly progress to patients having motor neuropathy, loss of consciousness, and both CRS and ICANS, if they become serious, they do require ITU involvement as well. Other toxicities like infections can occur, and typically the opportunistic infections, and they are usually more worrying in patients with hematological cancers who have previously received immunosuppressive treatment and neutropenic. And tumor lysis syndrome can also something that we monitor for, typically presented with metabolic derangement in patients with high tumor mutational burden. And these patients do usually receive prophylactic allopurinol rasburicase, for example, before their treatment. And then we discuss about some of the target antigen specific toxicities as listed here, which can be unique to each different therapies. And TGF-beta, for example, can cause anemia and could be at risk, can also cause increased risk of bleeding. So something that we need to be aware of in patients with head and neck cancers. So moving on, I'll talk about the antibody-drug conjugates, or ADCs. So these are antibodies which are combined with a chemotherapy agent in order to selectively deliver these chemotherapy payloads to cells expressing the target antigens of choice. So an example of an ADC is shown here. So you have your antibody component, which targets certain tumor antigens, most commonly TROP2, EGFR, for example. And it's combined with your chemotherapy payload, and typically the type of chemotherapy that is used is topoisomerase inhibitors, microtubule inhibitors that all act to disrupt DNA replication, for example, and it's combined by a linker which can be cleavable or non-cleavable. So these therapies are rapidly being indicated and researched across different types, including breast and urothelial cancers. Some of the design considerations of these ADCs is that the target antigen of choice should be highly expressed in tumors with minimal or less expression in normal tissue. And this is in order to reduce the off-target effects of these treatments. Another thing to consider is the drug-to-antibody ratio of these therapies. So if you have a high drug-to-antibody ratio, you may have a very potent drug, but increase risk of toxicity with narrow therapeutic index, for example. So this diagram further illustrates how an ADC works. So you have your antibody attached to the chemotherapy payload in red. It gets binded to the antigen, target antigen of the cancer cells, and the ADC will be internalized, usually towards the lysosomes of these cells. And then the payload will be released, either if by a non-cleavable, if the linker is non-cleavable, the ADC will degrade on its own and release the payload. If it's combined by a cleavable linker, is usually being degraded by quite specific enzymes within the lysosomes in order to release the payload. The chemotherapy would end, payload would then cause a disruption of DNA and DNA replication in order to kill the cancer cells. So there are many ADCs that are currently being researched in head and neck at the moment, but I thought I'd just go through three of these ones. So sacituzumab govitecan, it's an ADC that's currently being used in breast cancer at the moment. It targets TROP2, which is also highly expressed in head and neck cancers. Its topoisomerase and payload is in SN38, which is the topoisomerase inhibitor. It has a cleavable linker and quite a high drug-to-antibody ratio. So in their phase 3 trial in patients with locally advanced metastatic disease, they achieve objective response rates of only about 16%, so quite a modest response, with a median duration of action of 4.2 months. In terms of adverse events, typically related to GI adverse events. Unfortunately, vedotin or EV is also being licensed in bladder cancer at the moment in the States, and also highly researched in head and neck cancer. It targets Nectin-4 antigens, which is also highly expressed in head and neck cancer. And the chemotherapy payload is quite a common one we usually see with ADCs, which is MMAE. This time the drug antibody ratio is slightly lower. And in their trial, when they combine it, in this trial of EV202, which is phase 2 trials, we saw a slightly higher responses with 23.9%. And the median time to response was within 2 months. Toxicities wise were quite specific to EV were the peripheral neuropathy, skin reactions, and hypoglycemia that these patients needed to have. The last ADC is called MRG003, which targets EGFR, and it has similarly a MMAE payload, and their phase 2 trials also in the recurrent metastatic setting. And they did achieve quite a high objective response rate of 30.6% in their EGFR positive patients, which was the majority of the patients in this trial. And they had a median PFS of 4 months, which is quite similar to the other ADCs. And the toxicity related to it was more hematological toxicities. So some of the challenges with ADCs that we're dealing with at the moment, again, is due to treatment resistance. Similar to the bispecifics, there could be loss or downregulation of the target antigens, heterogeneity within the expression of this target antigens in tumor cells. And the cancer cells can also be surrounded by abnormal cell scaffolding, causing disruption in the processing of ADC and trafficking towards the lysosomes. And And the second challenge is the off-target toxicity. So only a small portion of the drug actually reached the target tumors. And one thing to consider in the design is either the on or off-target off-tumor toxicities. So, for example, on-target off-tumor are due to the fact that these antigens are also present in normal tissue, so causing dysgeusia, for example, in patients who receive EV. And off-target off-tumors when these ADCs are being released in the circulation and accumulate in specific organs. So these then subsequently lead to neuropathy and ocular toxicity, which is a big event that we normally observe in our patients. So one of the ways to overcome this is to use antibodies that are designed in a way that can be conditionally only activated within the TME and protected from releasing their payload in the healthy tissue. And in terms of efficacy, again, one way to increase it is by using different types of payloads, not only chemotherapy, but immunomodulators, for example, Lhnc or toll-like receptor agonists, and using ADCs in combination with other therapies might be proven to be more to increase the effectiveness as well. So indeed, there was a study looking at a combination treatment of both a bispecific and ADC called Isobrand. And these targets EGFR and HER3 in nasopharyngeal cancer. So this molecule is conjugated to a top one inhibitor as its payload, and it's got a high drug to antibody ratio. It targets EGFR, which is also highly expressed in nasopharyngeal cancer. And in this randomized phase 3 study, which was mainly conducted in China, they looked at patients with recurrent metastatic NPC who has progressed on 2 or more lines of treatment. So in this Kaplan-Meier curve, you can see that Isobrand had a more prolonged progression-free survival compared to chemotherapy group in blue, which was significant. And when you look at the waterfall plots, patients who receive Isobrand showed a much higher response rates compared to chemotherapy with a longer duration of response as well. So this data is looking very promising in this group of patients. When we look at the safety between these two groups, the treatment-related adverse events were generally quite similar. There were slightly higher grade 3 and serious adverse events in the Isobrand group, and there were 4 deaths which was observed as well, which were mainly related to hematological toxicities. So, but overall, I think the authors concluded that there was significantly improved response with over chemotherapy in the population that's heavily treated. So it'd be interesting to see how this drug fares in perhaps in trials done within the European population as well. So just the final few slides in terms of just to round up the lecture. So this is a systematic review of 23 trials involving head and neck squamous and NPC patients. So those in orange are the head and neck studies, head and neck patient studies, and those in blue are for nasopharyngeal. So overall, they observed quite a wide range of overall response rates, so up to 47% for ADCs and 37%, slightly less for the bispecific antibodies. However, there were more grade 3 adverse events in the ADC trials, mainly to do with myelosuppression from the chemotherapy payload, and slightly less were observed in bispecific antibodies, mainly to do with infusion-related reactions. There were 4 deaths which were noted, and they were all related to ADC patients in those trials. So to summarize, both bispecifics and ADCs have showed promising activity in head and neck and nasopharyngeal cancers. Many of these trials are within the phase 1 to 2 setting, but certainly more are coming up to phase 2 to 3. So it will be interesting to see the data from these randomized phase 3 studies. most of them toxicity seems to be manageable, but further training on specific toxicities like CRS and ICANS, which can be serious and often could be life-threatening as well, needs to be considered. And I think moving on to the further studies are needed to assess how we can better sequence these therapies in clinical practice, ways to overcome resistance and minimizing the toxicity of these therapies. So thank you very much for listening, and happy to answer any questions.
Thanks very much, Shin. I was going to just remind people to post their questions if they can. And thank you very much for your lecture. It's funny enough, I tuned into a podcast this morning, the Deep Margins podcast. I don't know whether you found it. It's head and neck. And they were talking about bispecific antigens on that. And it's a hot topic, as I'm a stupid surgeon, and I've managed to listen to something twice today about it. But one of the questions I've got, just as people collect their thoughts, I was just thinking in terms of the therapeutic window, you think of like a drug and its target. But if you've got, for example, a bispecific antibody, if one of the targets is giving you toxicity and the other one's giving you effect, if you're at that phase of a trial where maybe you're thinking about dose escalation and dose finding, can you also balance the two targets? If one of them's giving you more toxicity and the other one's giving you more benefit, is there a way of rebalancing the targets during that kind of phase 1-2 stage where you might need to do that?
No, that's an interesting question. So I think for the ADCs in particular, I think there are specific ways you can try to manipulate them. But yes, the ADCs do usually only bind to one specific target, and the toxicity is kind of optimized in a way by determining what the drug to antibody ratio is. For the bispecific antibodies, I'm not aware of any particular design where you can bind to one target more than the other. I suspect there would be some clever ways to do that, but I think a lot of it is also to do with how highly expressed these targets are in the specific tumor for a specific patient. So at the moment, we haven't got these therapies are not biomarker driven, so a lot of the patients receiving these therapies, we simply don't know what their EGFR expression is, for example. So they're just generally given to any patient, to all head and neck comers. But yeah, no, that's a good thought on how we can try to minimize the toxicities if we know one is causing more.
And I suppose a more fundamental question, and you think of these things when you're a non-specialist, there may be a really simple answer to this, and so I apologize if it's too basic a question. If you've got two targets and it's a bispecific antibody, why not just give two different drugs? Why not take a tablet that includes two drugs rather than one antibody with two targets? What's the pros and cons? What's the basic premise of it? Sort of going back to something really quite fundamental.
Yeah, I mean, I think I guess one can look at it in a more practical way. So if we can have just one treatment overall for the patient coming into in the chemo unit, that would help in terms of capacity wise and cost. And I think with the design of these therapies, it's a more sophisticated way of combining both therapeutic effects in one molecule, for example. And I think, as you can see, some ways that this bispecifics act as well is to target the T cells to kind of engage and synapse with synapse with the tumor cells. So the T cell engagers, for example, are quite important to achieve that effect. So there won't be any specific drug that can just attract T cells alone, for example. So I think there's more of a practical way, and I think, yeah, in terms of design, if we can have a molecule which can target two different antigens in a clever way, like the bispecifics, I think that's probably where the field is going towards. Yes, Terry.
Hi, Shin. Thank you so much for that talk. It's really good. Andrew's beaten me to it in the chat a little bit. So my first part of the question is that you said that there was a manageable toxicity profile for this, but from my perspective, that looked pretty sporting, a lot of that. With if you've got 20% serious TRAEs, that's strikes me as significant. So Andrew's question, which was the same as mine, how do you deliver that, or how deliverable is it in a real world population, if you like we've got in Liverpool with multiple comorbidities? That's point number one. And then my supplementary question was, how many of that that toxicity profile, how much of that is long term? How long is that? What is the long term profile on some of these things?
Yeah, so I think I'll answer the second question first. So the toxicity profile so for example, the CRS and ICANS, they normally occur typically within the first 2 cycles or so. So within the first 6 weeks, they don't tend to have a long-term effect on our patients. And having used some of these drugs in trials, obviously in a selected group of patients with good performance status, most of the CRS we see are usually mild, and only a minority will require further support. And because the trials are designed in a way to mitigate that as much as possible, so by using stepwise dosing, lots of pre-medication, and the CRF being well equipped in terms of monitoring, we do pick up any signs of early fevers very quickly before they start developing, dropping their blood pressure, tachycardia, for example. So I appreciate this is all in a trial setting. So yes, I agree. It's going to be a challenge when the bispecifics come to practice, when they're widely available for our patients. So there needs to be a wider training and awareness when we use these therapies, and when we start using these therapies in practice. I guess, again, in the beginning, as with immune checkpoint inhibitors, when they were first used in our patients, there's a lot of cautiousness, and we select our patients really well in the beginning as well. So I think it'll be the same when this therapeutics come into practice, that we will perhaps start off with a very selected group of patients as we get more confident in managing these toxicities, and as we get more data, we'll hopefully be more comfortable in managing them in a real world population, if you like. But there are lots of companies behind these trials who are trying to find ways to minimize the risk of toxicity using a different linker, and using and getting the right drug to antibody ratio, for example. Because you're right, it's still, we have a trial, for example, an ADC trial running in Cambridge at the moment, where almost all our patients that we see, about 60% develop ocular toxicity. So it's not without its risk.
Thank you very much.
No, thank you, Terry.
Well, if there aren't other questions, I'll bring this first red lecture to a close, and to thank Shin very much for launching our series the Head and Neck Centre in 2026. And one of the things that we have huge satisfaction in doing is sometimes, we'll see some translational research presented or some early phase drugs, but then within a short period of time, it's something we're able to offer our own head and neck cancer patients in our own clinics in Liverpool. And that's something that, we're very quickly able to close the loop from sort of bench to bedside, early phase into publications and so forth. So actually, we look forward to that, and we look forward to that happening over the next months and years. And I will keep my ears open to antibody-drug conjugates and bispecific antigens, and I will send a LinkedIn post when we recruit our first patient to one of these studies. So thanks to everybody for joining us. Thanks to Debbie for convening this and doing the admin. Thanks to Shin for presenting. Have a good evening, everybody. And please do remember, we're back sooner than you think, actually just next Tuesday. And then it'll be weekly from Tuesdays on. And so there'll be 5 lectures through January, February on Tuesday evenings from here on in, not Thursdays. Thanks, everybody. I'll let you all go. Bye-bye now.
Thank you very much, everyone. See you.
Thanks, Shin. Bye-bye.